It's interesting in coming to an event like this, one of our guests who's speaking tonight, Ray Nagin, was detained for 6 days in Shanghai, as I read on an email earlier in the week, because of the concerns about the fact that he was sitting near a passenger who had symptoms of swine flu, or at least a flu, on his way through to Australia via China. So there's a very current case study to talk about, to get our teeth stuck into in terms of a global phenomena and a public health phenomenon. So it helps set our agenda very nicely. Not that these things, global health panics, are new. When you think about it, in the 14th century, the Black Plague killed a third of the population of Europe. So we think everything's happening for the first time, but it ain't necessarily so. When you think about the pervasive influence of Western countries affecting everything in terms of the opening of markets, trade, also travel these days, along with this comes obvious evils. Back to colonial times, you can think of the introduction of diseases, but even now, sort of packaged diseases like tobacco, and Western companies seeing the declining local markets being more than made up for by penetrating countries that are less regulated around tobacco, like China. So that is a public health issue. AIDS, and we'll talk about this in the course of the next hour or so, is another example of where, with freeing of markets and travel, the spread of diseases like this has been contained in very different ways, or not contained, according to the geography, and different public health approaches in places like Australia, the UK, versus the United States, versus countries of Africa, have led to very different outcomes. So we've got a very august panel to talk about these things, and I'll just slightly formally introduce them. Larry, as Jeff was saying, is just hot off the plane, but the good news is he's staying for 6 months with the US Studies Centre. He's director of the Centre for Law and the Public's Health, which is a collaborating centre of the World Health Organization and the Centres for Disease Control and Prevention. That's one of his roles, which comes as part of the package of being Professor of Global Health Law at Georgetown University in Washington. He's also a Professor of Public Health at Johns Hopkins University. So it's a partnership between these two universities that leads to the Centre for Law and the Public's Health. He spent a lot of time in Europe. He was awarded, interestingly, by the UK National Consumer Council as the person who has most influenced Parliament and government to act for the welfare of society. So there's an accolade. And in the UK, Larry was the director of the National Council for Civil Liberties. So he's particularly interested in health law around people with disabilities and the like. And hopefully we'll get to that part of your knowledge base during the course of the discussion. Don Nutbean has been appointed Vice-Chancellor of the University of Southampton recently. He's been fulfilling the role as Pro-Vice-Chancellor in Health Sciences at the University of Sydney. He was Head of Public Health in the UK Department of Health for 3 years. And that role gave him oversight of issues such as health inequalities, the prevention of heart disease and cancer, drug misuse, treatment and prevention, and sexual health. And interestingly, Don's saying in his new role he's been able to negotiate some continued academic role. So he's not lost to public health by soon moving to Britain. And Stephen Leader is Professor of Public Health and Community Medicine at the University of Sydney and Director of the Menzies Centre for Health Policy. His research interests in epidemiology have mainly focused on asthma and cardiovascular disease, notably in developing countries. And his interest in public health goes back to spending a year, I think in 1968, in the highlands of Papua New Guinea. So there's our panel. Larry, you're a technical advisor to WHO. Tell us the state of play on the global pandemic of swine flu, if I'm permitted to call it that.
Okay, well, thank you. Well, I apologize, first of all, if I'm a little bit incoherent, because I have been just traveling for about 36 hours. It's very fitting that I should be here, because I'm going to be at the US Studies Center for the next many months, and also Harvard University is part of the sponsorship, and I'm currently writing a book on global health law for Harvard University Press. So I thought what I might do is just very quickly talk about what I see to be some of the major streams, the most important themes relating to globalization, sustainability, and global health, and then apply that to the current H1N1 outbreaks. It seems to me that There are clearly two kinds of diseases that are very important. Steve has been very much involved with non-communicable diseases. We mustn't forget that because they're extremely important in terms of heart disease, respiratory disease, and the like. And there are communicable diseases, endemic ones, now endemic, like tuberculosis, malaria, and even now HIV/AIDS is endemic in many parts of the world. And then novel forms of infectious disease, whether it's the current H1N1 outbreaks or SARS or the scare that we had with avian influenza. But those are the kinds of manifestations, but how do we kind of think about globalization and sustainability in terms of what the international community needs to do? So I've been writing chapter 1 of the book, and it seemed to me that there are important themes. I mean, the first theme is health systems. Really to have strong health systems throughout the world that are able to provide primary care, child maternal health, and other areas. These are the kinds of basic things that every human being needs. Secondly, is the idea of public health systems. Public health and healthcare they're interrelated, but they're not the same. So the International Health Regulations, for example, says that every country has to have the capacity for surveillance, containment, control of outbreaks, and yet capacity is nowhere to be seen. And the WHO doesn't have the capacity to do that. Its agenda in many ways is controlled by rich countries, the United States, the European Union in particular. And so it's not been able to exercise leadership. Therefore, you have a number of other mechanisms that really kind of skirt around the WHO, like the Global Fund that Peter said that we might be talking about. And then thirdly, is what I call a basic needs approach. One might call it a little bit like the Millennium Development Goals. But it seems to me that we really, if you think about it from a common sense point of view, we know what makes human beings healthy. We just don't do it. And what makes them healthy are basic needs. It's clean air, clean water, sanitation, hygiene. These are the kinds of basic needs, and I would add to that essential vaccines and medicines, and making access to not necessarily very fancy ones like we were talking about antiviral medications, but really basic medications that can really do a lot. And so in thinking about that, we want to have basic needs, health systems, public health, as really kind of core horizontal ways to think about global health. And even though that's what we should do, we don't do it. Now, how does this all involve the current H1N1 crisis? As Don's going to tell you, it's not a crisis, not yet. And it's probably not likely to be. Although the 1918 Spanish flu in its first wave was relatively benign, as this one is. And so it could change. It's very low likelihood that it will, but it could. But other than that, it behaves very much like seasonal influenza, which is actually more dangerous, but just not as novel. But it is the first time, and I just wrote an article that came out yesterday in the Journal of the American Medical Association, called Pandemic Preparedness Under the International Rule of Law. This is the first time the international health regulations, the one global treaty on communicable diseases, has actually operated. And it'd be interesting if we did a report card on that during our conversation. If I were to give it a grade, it would be a C, and we can explain why later.
Okay, I'll come back to the grade of C. Steve, do you want to pick up the conversation?
I think what Larry's been talking about are clearly iconic elements in most people's understanding of global health, and that is whoa, what's the latest bug that's in circulation and how dangerous is it? This says a lot about our perception of risk. And that's based not on numbers, but on myths and fears and all sorts of things. If you took 100,000 people, all of whom had swine flu, and said, what's the likelihood of one of them, took 1,000 people at least with swine flu, what's the likelihood of one of them dying in the space of a year? One person. In the same group, there'd be 2 people who would die of heart disease over the same interval. But for reasons that have to do with the history of the way we perceive infections and epidemics in particular, one gets attention and the other does not. So we've developed an agenda for global health which is focused very much on HIV, TB, malaria, maternal health, which it isn't because it's only focused on a little bit of maternal health. The biggest killer of women during the childbearing and family formation years are heart disease, stroke and other problems like that by a factor of 4. And yet we don't say anything about that. We just concentrate on delivery and the acute events in the first 2 years of the child's life. So if you took the agenda for global health that's sort of sitting over here, which everybody nods at and Bill Gates pours billions into, and on the other side said, well, what are the problems troubling the world? Sure, some of them would feature in this list, but there'd be a whole lot of stuff that no one takes the slightest interest in.
Well, can we go a little further on this issue of risk and myths? There are smart people like you three. Why does the public health system not have a more sophisticated approach then to these issues?
I don't know that it is the public health system per se. I think it's the way in which socially we construct these ideas about infections and risk. And that owes a lot to our educational understanding of the history of disease, the way in which we perceive our own lives. I doubt that it's got much to do with the public health agenda or that public health can be held responsible. It's an agenda that's developed from common understandings that are part of the social fabric of society. They may date back to times when epidemic disease was a very frightening thing. It's not long ago that we had poliomyelitis and other problems like that cascading through the community. And still, those memories, like memories of the economic depression, are ones that shape how we view the world today. But, for example, there was a story told about a person approaching the Gates Foundation to do something about tobacco control in China, where they have 3 million deaths a year, I might say, from heart disease and stroke, which tobacco smoking is a key element. And the story ran that the Gates Foundation people said to them, well, no, smoking is a personal responsibility, and when you convince China to stop producing any tobacco or manufacturing cigarettes, you come back and talk to us then, as though that solved the problem. So it's outside the purview of many of the major granting agencies that determine the agenda of academic institutions through their grants as to what is researched. If you look at global health in the US in particular, most of the academic agenda is focused on communicable diseases, not because this has come from a broad appreciation of the things that are troubling the world, but because there's money to pay for academics to research it. So it's a circular mythology, if you will, that needs to be really seriously challenged. And sure enough, I mean, no one's saying, I hope, that infectious disease is irrelevant or that pandemics are not important and don't need to be taken seriously, but it's a bit like regarding a breakout of some world war as the total battle, which it's not. It's part of the game, part of the war that needs to be addressed, but there's a whole lot else out there that deserves a lot more attention than it's been getting. This is a social justice issue for Larry, I would say. What about all those people who suffer from non-communicable disease for whom there is no aid money being given at all? No impact on urban design in developing countries, No concern about Australia shipping high-fat meat remnants that it can't sell in this market to the Pacific where they're sold and make the people fat. No real concern about tobacco that's manufactured and sold offshore, so long as we keep Australia clean. There's an awful lot in that agenda that is unjust.
Good. I mean, bad, but we're good. We can move on. Don.
Thanks.
Can I just pick up on one thing? You might touch on the fact that you've written recently an open letter criticising the nature of the way academic research in public health is handled in this country. It's a parting shot.
Well, yes, I have written a letter criticising the fact that an excellent review of public health research has been delayed in its publication by the government, yes. Thanks. We can pick that up later if you're really interested. I offered to go last because, A, I was hoping there'd be nothing left to say, and B, I hadn't actually worked out what I might say if there was something left to say. I think I'd like to just... we're moving around between something that's called global health and a discussion of the impact of globalisation on health, and whilst there are some points where those two concepts intersect, they are actually slightly separate issues. For me, globalisation is largely about the intensification of technology, economic and social interactions that were occurring at a particular pace being greatly intensified over the past decade or so, and producing a very significant impact on the whole world through that intensification of interaction. There have been some really important and positive benefits for the health of the public as a consequence of this intensification of interaction. In some countries, China would be an obvious example. A very large number of people have been brought out of abject and relative poverty. And because of there's such a fundamental relationship between poverty and health, that's a good thing. There's been an intensification of the exportation of health knowledge and some technologies, and we've heard reference by both Steve and Larry to certainly some of the technologies that have been transferred at a more intensive pace. And it's fair to say there have also been the development of a range, in public health terms, of a range of important social and technical networks that have facilitated the flow of information and technology. On the other hand, whilst this intensification of interaction also makes it easier for infectious disease to spread, I do actually think that's a bit of a distraction, and we're particularly overexcited about what is at the moment a relatively mild form of flu. And if we're not distracted by it, it's fair to say the media are, and as a consequence, politicians have become very distracted by it. But actually, on the downside, in relation to globalisation and health, we've also seen an intensification of the marketing and trade in a whole range of unhealthy products. So we've had reference already to intensification of trade in tobacco and in unhealthy foods and a range of other unhealthy products. That's not a good thing for health. I have to say it's also led to an intensification in the export of significantly irrelevant and unduly expensive healthcare technology. And again, work that I've done in China over a decade or more is a very good illustration of this. So on the one hand, one of the effects of globalization and the opening up of China to the global economy has been this very positive outcome in terms of poverty alleviation for a significant number of people. On the other hand, I see companies from Europe and North America all the time in China basically trying to promote the adoption of a westernized tertiary healthcare system, when for very large parts of the country still, basic immunization services and the most basic primary healthcare still doesn't exist. So on the downside, on the negative ledger, there is an intensification in the promotion of significantly irrelevant health technology. I also think that sort of related to that, it has led to a distraction from very basic preventive healthcare programs, health promotion programs, and the building of solid foundations in the more traditional public health, maternal and child health, primary health care, health education, and health promotion. The other thing to say, and again, just in relation to the main theme of this, one of the themes of this conference, what's been the effect of the global financial downturn crisis? Depends who you are as to whether you think it's a crisis or a downturn. As Jeff said earlier, I'm very relaxed and I just see it as a downturn, but for others it's a crisis, of course. But the reality is that many of those brought out of poverty as a consequence of globalization are also the first and the fastest to be brought back into poverty. I have to say it's a matter of great distress from a personal point of view to have been part of the Blair-Brown efforts to reduce poverty in the UK in the first 5 or 6 years of the Blair-Brown government, to see that just in the last 18 months that what has been a very impressive trend in getting families with young children, for example, out of relative poverty has actually reversed in the UK as a consequence of the global financial crisis. And so these families who were offered a measure of protection to their health as a consequence of globalisation are the first and the fastest to fall back into poverty as a consequence of the globalisation of the downturn. So where does this all lead us? Well, in my view, I guess it's all very simple, really. First of all, we have to place health somewhere into the discussion of globalisation, that somehow it's not just about an intensification of trade and economic interactions, but that we have to consider ways in which we can place health as a value within that set of intensified relationships, and in doing so, take the sorts of actions that are going to maximise the benefits of globalisation and minimise some of the harms that I referred to earlier through better regulation and government. And that will require people like people like the three of us here to become involved in a very active way in monitoring the health effects of globalisation, and speaking up and advocating in ways that will maximise the benefits, minimise the harm.
Larry, how do you respond to what Don's just said?
Well, I actually agreed with every word of it.
Dan.
I did agree with every word. I mean, globalization is often thought of as a negative term, and it can be very negative. First, one does need to say that there is a very strong link between socioeconomic status and health, and and globalization has been responsible for lifting people out of poverty, therefore making them healthy. I think people, particularly activists in global health, don't recognize that the way they should, and they think that commerce in and of itself is a bad thing. But if you look at the bad parts of globalization, it would certainly be that medicines are unaffordable. Peter and I talked about the TRIPS agreement, which is the protection of intellectual property in trade as part of the World Trade Organization. Many activists find that patent protection given to medicines, particularly in the AIDS community, the activists in the AIDS community, believe that it's made drugs unaffordable. And there's a certain truth to that, but it's also complicated. Picking up from Steve's point and linking it to globalization, it's very interesting because we think of globalization as the kind of the rapid spread of infectious diseases, and it's certainly that is true. You can, with intense, overpopulated interchange between people and animals, places like Asia and Africa and now in parts of Latin America, one can see infectious diseases sweeping across the country. But it's also true for non-communicable diseases, but we just don't see it that way. I've often said, and I think the last time I was in this room in Sydney, I mentioned it, you can go to any major city in the world, whether it's Hong Kong or Beijing or Mexico City or New York City or Sydney, and put yourself in the center of the city and do a 360-degree turn, you will actually see pretty much the same thing. It will be a KFC, a McDonald's, a Dunkin' Donuts, Johnny Walker whiskey, chocolates. In some places you'll see gun shops or porn shops. That's mostly in the States. But
I missed lunch, and I'm really, you just stop going on.
I just did it for you. But that's the negative side of globalization, and it's what is driving the heart disease and other forms of ill health from non-communicable diseases. So globalization has its benefits, but also it has its deep flaws.
Steve.
To pick up on Don's point, my view of it is that we need to have health at the table when globalisation or development is being considered. And prototypically that focuses in on a thing like urban design. If you don't have the health people there making their voice heard alongside the others, then you get cities that are not conducive to good health. But it's not a matter of saying, I think that this is an error that we've made in public health, that there is no conversation to be had with McDonald's or KFC or these other groups at all. There is a conversation to be had, so that you can moderate the development in ways that minimise the deleterious health consequences. So the concept I would have of globalisation in relation to development, given that half the world's now urban and there's no reversal of that trend in sight, is that we need to define who's going to be at the table to discuss how we're going to make progress. And by excluding various groups, and I have to say that health has not been a member of the group that's been having those conversations to any great extent, then you run the risk of almost inadvertently setting yourself up to the epidemics of non-communicable disease.
Don?
Yeah, I just wanted to, I'm stimulated by all this discussion of food and drink, but I've certainly made myself unpopular with some of my colleagues in the public health community because I don't have a strong view about whether or not there's a McDonald's on every street corner. I'm very interested in what they sell. And the truth is, they provide they provide a fantastic service that people value. They provide products at a price that people can afford, even in poorer communities. And the issue for me is, can we as public health activists not try to close McDonald's down, but change what they sell? And can we work with McDonald's to alter the types of food and the constituents of the food that they sell? And the answer is, demonstrably, that you can. They are a market-driven organisation. If we can demonstrate to them that there is a market for healthier foods and that people would buy it if the choice was available, and that they can continue their business, then we have a win-win situation. And McDonald's have made very significant changes to what they sell, and the constituents of their more traditional foods. Now,
tobacco companies different?
Tobacco companies black and white. There isn't a safe cigarette.
There's always been there's interest in the tobacco industry to create one.
I'm sure there is. I'm sure there is. However, I think that's irrelevant. If I can just give you one more example of how we should try to work with the masters of globalisation and try to position health more clearly in the globalisation agenda. I've been working, not very much, but a little bit, with a campaign to try to persuade Coca-Cola, who have, frankly, the best distribution network in Africa, to use their distribution network to deliver essential medicines. They, frankly, can deliver Coca-Cola to pretty much any corner of Africa, and we, in public health, seem to be miserable at achieving the same goal. So why not try to work with the grain? Why not always reject the fact, as I say, I do have colleagues who are anti-globalisation and would have McDonald's and Coca-Cola as number one and number two in their sights. But there are ways of thinking about how, by inserting health into that discussion, how can we maximise the health benefits, minimise the health harms? If that's a starting point, you can have completely different type of discussion.